can alter the non-coding RNA content of the sperm and the eggs, transmitting the information to the embryo. So now we do understand that even a temporary, there is one more.
1 minute more. Sir.
1 minute.
1 minute more.
So the implications of such transmissions is like family history. In future, taking the family history shouldn't stop with just ancestral father or grandfather. It has to take into account the entire ancestral environment too. So just having diabetes in father or grandfather is not enough. A non-diabetic grandfather exposed to a famine or overeating could be a risk here. So we will have to be very clear in taking that history also. And of course, we have been very diligent in treating the GDM or whatever it is, metabolic abnormality in the mother. Now we will have to prepone it while planning the pregnancy itself. So these epigenetic, that's it sir, finished sir. So these epigenetic interventions can mitigate the disease. The future is epigenetic modification, sRNA biomarker discovery, and of course ethical framing. So what is the take home message? So if you are ill, don't feel guilty, blame your grandpa. And of course, if you don't want your offsprings or your grandsons to be ill, try to get your children married before they develop any metabolic abnormalities. So get them married early.
Thank you, Dr. Vengo sir.
Thank you
for your nice presentation and very new informations and insight into this very good but different and unusual topic. Next I call upon Dr. Joseph Panneerselvam sir, diabetologist from Trichy, and he is going to talk on metabolic surgeries.
A very good morning, one and all. At the outset, I would like to thank the organizing team of TRAC 2025 and Balamurugan sir for giving me the opportunity. So my topic is metabolic surgery. As we all know, so the obesity is and related type 2 diabetes and other disorders, they are increasing in a pandemic proportion. So we have medical management of obesity and these disorders, but they are not adequate to address the complications. So now the focus is shifted to metabolic surgery. Actually, it's not a new concept. So these surgeries have been started in 1960s itself. So we are going to discuss. So I'm going to discuss about this metabolic surgery. What's the role of metabolic surgery in treating obesity and related metabolic conditions? This is all the agenda. So the obesity and type 2 DM, they go in hand in hand. So metabolic surgery is an important option to achieve substantial and durable weight loss, because the medical management may not be able to bring about desired weight loss. So the substantial and durable weight loss is possible with the metabolic surgery. So the mechanism seems to extend beyond weight loss, and reduction in CV risk factors translates to better outcome if we go for metabolic surgery. And what is metabolic surgery? So these are the range of procedures that modify the stomach or small intestine to either restrict food intake or reduce nutrient absorption, or both. These are the very important mechanisms. Either they have to restrict the procedure, they have to restrict the food intake or reduce the nutrient absorption from the duodenum, or some of the procedures they provide both. Lead to significant weight loss and improvement in metabolic conditions like type 2 DM, hypertension, obesity and sleep apnea and other related disorders. So the pathophysiology of obesity is very complex. So the many factors they contribute to the development of obesity, like environment, epigenetic, genetic, physiologic, socio-cultural, and so many factors are responsible for the development of obesity. So the obesity is graded by using body mass index. So the normal BMI is 18.5 to 25, and overweight 25 to 30, and class 1 30 to 34, 34.9, class 2 obesity is 35 to 40. Any BMI more than 40 is classified as morbid obesity or class 3 obesity. These metabolic surgeries, they play a very important role in the last two categories. So either morbid obesity or patients with class 2 obesity with comorbid conditions. So these are all the obesity associated conditions. So the type 2 DM hypertension, dyslipidemia, obstructive sleep apnea, arthritis, GERD, non-alcoholic fatty liver disease, PCOS, and clinical depression and functional impairment. These are all the concepts or disease conditions associated with the obesity. And it can produce variety of complications from head to foot. So all the systems are involved. So with the obesity, so we have to find ways to control this obesity to prevent these complications. And we have medical management. So variety of drugs are available for the treatment of obesity, but they are not adequate. So these are some of the limitations. So the weight loss is only the modest. So only we can achieve modest weight loss, and often it is not durable. Whenever the patient stop the medications, there will be rebound increase in the weight. So the drug intolerance adverse effects also one of the reason for the non-compliance from the patient side, because we have many drugs starting from orlistat and this phentermine, and recently GLP-1 receptor agonist also they are using for weight loss. But the drug intolerance is a major issue, like GI disturbances can occur, patient can have diarrhea and bloating abdomen, all these things that the complaints be decreased from the patient side. So they have got different efficacy and safety profiles. No general treatment algorithm is available, because the treatment should be individualized. For each patient will require different treatment approach. These are some of the limitations of medical management. And what are the benefits of metabolic surgery? So it provides significant and greater weight loss. So up to even 50 to we can achieve 50 to 60 kg weight loss also maximum, and it improves diabetes control, and it can achieve remission in majority of the diabetic patients after metabolic surgery. So many patients, so they remain free from diabetes. So remission can be achieved, and there will be improvements in other obesity and related conditions such as hypertension, and even the cancer incidence also will come down significantly. So the patient will have better quality of life, and the sense of well-being, physical well-being will be there after metabolic surgery. And what's the rationale for metabolic surgery? So due to the tendency for basal metabolic rate so to decrease with the dieting, most people will regain all their weight returning to the previous homeostatic set point. This is the problem with medical management. Whenever we perform metabolic surgery, it appears to alter this mechanism and reset this point. So the points will be reset with a 15 to 20% of weight loss and maintenance up to 20 years. So the weight loss is durable over the period of 20 years. This leads to long-term survival benefit and improves obesity-related diseases and quality in life. And there are various mechanisms. So for this metabolic surgery, so it extends beyond weight loss. It's not only weight loss. So it is the benefits are beyond weight loss. It causes depletion of liver fat and subsequent improvements in the hepatic insulin sensitivity and clearance. There will be very good improvement in the insulin sensitivity. So the improved incretin levels is another factor responsible for the better outcome, and the changes in the inflammatory and adipokine profiles also noted. This is the flow chart. So after performing metabolic surgery, it causes, so the patient will decrease the calories and increase ileal nutrient delivery instead of duodenum. So there will be malabsorption, and there will be increase in bile acids, and gut microbiota also improved. So the ultimate results are decrease in weight, increase in incretins, and decrease in insulin resistance, and increase in insulin secretion. Ultimately, it causes diabetes remission or improvement, and so the final result is decreased cardiovascular events and decreased mortality. So this is what are the inclusion criteria. So the patients, you have to select the patients correctly for better outcome. The age should be between 18 and 60 years, and body mass index should be more than 40. That means morbid obesity, and the patients BMI of more than 35 with a significant comorbidities such as heart disease, diabetes, hypertension, sleep apnea, and so on. And there's we can consider metabolic surgery if the patients with the BMI of between 30 and 35 if their diabetes is poorly controlled with the available means. The history of prior weight management attempts and motivation and engagement in lifestyle modification. So we can select these patients from this category. And what are the exclusion criteria? So patients already having cardiopulmonary disease and current usage of illicit drugs, tobacco use, and alcohol use patients should be excluded from this treatment. And lack of comprehension, reversible endocrine disorders with obesity, because since a reversible cause, we need not do complex metabolic surgery in this group. So uncontrolled severe psychiatric illness is also a contraindication. And this is algorithm how to select the treatment option for patients with obesity. So we have to divide based on the BMI. If the patient's BMI is less than 30, so we can go for non-surgical management. If it is more than 30, so we have to divide whether it is class 1, class 2 and class 3. So class 3 patients, straight away we can recommend metabolic surgery. And class 2 patients, if the lifestyle management and medical management is not sufficient, so we can recommend metabolic surgery. And in patients with the class 2 and class 1 obesity with the poor glycemic control, we can consider doing metabolic surgery. This is algorithmic approach. And what are the surgical options available? So we have 3 mechanisms by which the surgical procedures work. One is restrictive procedures. That means we are restricting the intake of the so by restricting the capacity of the stomach, by performing sleeve gastrectomy and gastric band surgery and vertical band gastroplasty. And malabsorptive procedures, the bypass, jejunal-ileal bypass will be done to bypass the duodenum. It prevents the absorption and causes malnutrition. That way it improves the weight loss. So some of the procedures, so they provide both restrictive and malabsorptive. The examples are Roux-en-Y gastric bypass surgery, duodenal switch surgery and sleeve bipartition. We'll discuss one by one. So this is a Roux-en-Y gastric bypass surgery. It is started way back in the year 1960s. So here they will construct a small pouch in the proximal stomach and they will connect it to the distal jejunum by bypassing duodenum and proximal jejunum. So thereby it causes both restriction of intake as well as the absorption defect. Thereby it works very well. So it provides a greater weight loss up to 60 to 80% and changes in the gut hormones that reduce appetite and enhance satiety, and typical maintenance of more than 50% excess weight loss. The disadvantages are the procedure is very complex and it can produce vitamin and mineral deficiencies. It requires longer hospital stay, and some of the patients they can develop internal hernias also. The next one is sleeve gastrectomy. Here along the lesser curvature, so they will resect the greater curvature. 70 to 80% of the stomach is resected. The remaining part of the stomach will form as a sleeve. So it's a very small portion. So there will be restricted intake, and there won't be any malabsorption here. Only the intake will be restricted. This procedure also started in 1960. Here also the significant weight loss can be achieved. So the hospital stay is shorter, and it changes the gut hormones to improve the satiety. So it will reset this neurohormonal mechanism, thereby it improves the satiety and causes weight loss. So disadvantage is a non-reversible procedure because the greater curvature of the stomach is resected, so it cannot be reversed. And again it can produce vitamin deficiency, there will be leak, and potential weight regain also is there. It's the disadvantage. And the third one is the duodenal switch. Here also they will perform the jejunal-ileal bypass to bypass the nutrition absorption from the duodenum. And again it provides greater weight loss, and this allows patient to eat near normal meal because the stomach capacity is not restricted. Advantages and disadvantages are has higher complication rates and the risk of mortality. It requires longer hospital stay. It's a complex surgery. And this one, next one is vertical band gastroplasty. Again, so they form as a pouch, small pouch, by stapling the stomach in the proximal portion. Thereby their intake will be restricted, and so there will be restricted caloric intake, and it provides weight loss by this mechanism. So the last one is adjustable celastic gastric band. It's a very simple procedure. So they will fix a band in the proximal stomach to restrict the stomach quantity, and the port placed under the skin. So we can adjust, we can inflate the pump. So by injecting saline, so it can be inflated or deflated. So by this mechanism, the stomach capacity is restricted. So there will be decreased intake and ultimate weight loss. So what are the clinical trials data to support? So this is a 5-year, they have studied In this trial, they have studied 5-year changes in body weight and the rates of diabetic remission and changes in glycated hemoglobin. The first one is changes in body weight. So it's a greater weight loss achieved.
Joseph sir,
Yes.
kindly finish it in another one
Yes.
more minute.
Okay. So the next one is the diabetic remission. Remission at the end of 5 years is very much greater in patients, those who are undergoing this procedure.